Well, welcome to this podcast on the laboratory diagnosis of adrenal insufficiency for primary care physicians. I want to emphasize this is going to focus on the laboratory diagnosis and just mention a little bit about treatment. My name is Hershel Raff. I'm a professor of medicine at the Medical College of Wisconsin in Milwaukee, Wisconsin, USA. I have no disclosures relevant to this presentation. So as a clinical physiologist, as well as a clinical laboratorian, I always start out with physiology. And a lot of doctors like it. Oh, I remember seeing this when I was back in school. Remember, there's two inputs to the hypothalamic pituitary adrenocortical axis. There's stress inputs like pain or a burn or test anxiety. And then there are the non-stress inputs, mostly the circadian rhythm, where cortisol peaks in the morning and is at its nadir at bedtime. These inputs merge on the hypothalamus, which releases these factors into this portal blood supply. The factors are CRH and vasopressin, corticotropin releasing hormone, and vasopressin. They stimulate the anterior pituitary to make ACTH. And incredibly important for this disease is the two meanings of the letter T. There's tropic, which means I want some cortisol right away. It's like a light switch. Bam, give me some cortisol. But then there's the trophic actions, the growth promoting effects, where it maintains the plumpness and the health of the adrenal cortex. So that if ACTH is very low in secondary adrenal insufficiency, which we'll get to, the zona fasciculata and reticularis, the part of the adrenal that makes the steroids we're going to talk about today, actually atrophies. Just like if you put an arm in a cast, the muscle will atrophy. But remember, the zona glomerulosa of the adrenal makes this other really important hormone called aldosterone, which is a mineralocorticoid, affects sodium and potassium balance in the kidney. And the main controller of aldosterone, not the only one, but the main controller is the renin, and it is pronounced renin, by the way, as in renal artery, renal cortex. And angiotensin 2 stimulate aldosterone. And this will become extremely important when we talk about differential diagnosis. So the adrenal cortex is a fascinating gland. You can't live without it. You can live without the medulla. You can't live without the cortex. And it has three zones. It has the zona glomerulosa that makes aldosterone, again, primarily controlled by the renin-angiotensin-aldosterone system, and also by plasma potassium. The main thing of focus today is cortisol and adrenal androgens. Now, the androgens made by the adrenal, in adults at least, are relatively weak androgens, but they're great usefulness in diagnosis. And again, this is mainly under the control of ACTH from the anterior pituitary. So adrenal insufficiency is basically inadequate endogenous cortisol secretion from the adrenal gland. It's just not doing its job for a variety of reasons we'll get to. Now, this is what I teach the medical students, and this is the best way I think to think about it. Again, a protein disease. It can look like a lot of different things, and you just don't want to miss it because of its lethality. Fatigue, malaise, lack of energy, GI, some nausea, vomiting, anorexia, and weight loss, and low blood pressure and hypovolemia, leading to dizziness and orthostasis. But the best way to remember this is if you see the combination of weakness, fatigue, anorexia, and weight loss, otherwise unexplained. Obviously, if the patient has severe cancer or, is extraordinarily anemic or something like that, it's different. But if you see weakness, fatigue, anorexia, and weight loss, at least think about adrenal insufficiency. It doesn't mean you have to test for it, but have it in the back of your mind. The largest lawsuit in the history of the state of Wisconsin up until a few years ago that I know of was a failure to diagnose adrenal insufficiency. There's two general types: the loss of adrenal function, all the zones of the adrenal cortex. So the cortisol is low, the DHEAS is low, and the aldosterone is low. because of the loss of the negative feedback, ACTH is always, we don't say always much in medicine, is always increased until the patient's treated, obviously. Renin is also often increased because of the loss of aldosterone and the body's response to that. In fact, as you know, in primary adrenal insufficiency, ACTH can be very, very high. I mean, hundreds of times normal. And because ACTH contains within the sequence MSH, melanocyte stimulating hormone, it can actually cause some hyperpigmentation, particularly in the palmar creases and buccal membranes. That's a great sign. It's not always present, but it's a useful sign. Now, Addison disease, first described by Thomas Addison in London in the 1850s, is a subtype of primary adrenal insufficiency. And it certainly shouldn't be used to define secondary adrenal insufficiency. But there's actually some forms of Addison disease, of adrenal insufficiency primary, that are not Addison disease. They're not synonyms. And this, obviously, if you're losing all the zones, have to be treated with both hydrocortisone, which is cortisol, and fludrocortisone, which is the mineralocorticoid agonist. Notice I didn't list DHEAS on here, or DHEA. There's some discussion about maybe some adults should get some DHEA and maybe they'd feel a little better, but the jury's out on that one. Now, secondary and tertiary adrenal insufficiency is an inadequate trophic action of ACTH. So it can be due to pituitary or hypothalamic hypofunction, leading to adrenal atrophy. Now, this doesn't happen overnight. It takes weeks for it to develop. So if somebody loses their pituitary function today, they're not going to have secondary adrenal insufficiency tomorrow unless their ACTH is 0, which it never is. But it's due to the atrophy of the adrenal over time. And this is only treated with hydrocortisone or cortisol, same thing, because the renin-angiotensin system's intact. You don't need to give fludrocortisone. In fact, it may be dangerous to give it, and you lose control over their potassium. So here's primary adrenal insufficiency. Morning cortisol is low because you've destroyed the adrenal cortex. Morning plasma ACTH is always increased because of the loss of negative feedback. You've taken your foot off the brake, basically, and the car's just running away. Morning aldosterone is low because you lose zona glomerulosa function, and morning plasma renin activity is increased because of the loss of aldosterone. Secondary adrenal insufficiency is actually fairly common for reasons that I'll show you. Spontaneous, maybe not that common, but iatrogenic, common. Morning cortisol is low, sometimes not that low, because if there's a little bit of ACTH left, you can keep some of the adrenal gland going. Furthermore, because of that, morning plasma ACTH is inappropriately not elevated. It's not usually below the reference range, although it can be, but it's inadequate to maintain adrenal function. So my ACTH could have been 40 last week, and it's 20 this week, and my adrenals atrophying, even though 20 is quote unquote normal. Well, there is no such thing as normal in this scenario. It's abnormal, even though it's in the reference range, because it should be high if the pituitary was normal. And then, of course, because the renin-angiotensin system and aldosterone system is intact, they're typically fine. And that's another reason why these patients typically their symptoms are not as severe. So again, what are the causes? Well, primary is destruction of all the zones, and what Thomas Addison described is autoimmune, although he didn't really know it was autoimmune. We now know it is. Most of his patients were TB or granulomatous diseases, so infectious, and hemorrhagic, and lymphoma. So I think 1 or 2 of his patients might have had lymphoma. I don't remember. But we now know there's some very rare genetic and familial forms. So the fact of the matter is, it's not really that bad to call primary adrenal insufficiency Addison disease, because it's typically one of these top things. Secondary adrenal insufficiency is more complicated, and more subtle. So the zona fasciculata and reticularis atrophy because of the loss of the trophic actions of ACTH. So cortisol and the DHEAS are low. However, because the renin-angiotensin system's intact, zona glomerulosa is just fine, and it pumps out aldosterone, and that is attenuates the symptomology. Now, a cause that's made up of a bunch of little causes is hypopituitarism. Some people used to call it panhypopituitarism. It has many, many etiologies: trauma, infection, cancer, checkpoint inhibitors that are used in cancer therapy. Glucocorticoid withdrawal syndrome, you all know about. If you put somebody on prednisone for long enough and suppress their ACTH for long enough, their adrenal will atrophy. And if you stop the steroids too fast or stop it abruptly, they will get severe glucocorticoid withdrawal syndrome. Not an optimal situation. At least in where I am in Milwaukee, we have a huge problem with opioid abuse. And it turns out that opioids, in addition to suppressing the gonads due to hypogonadotropic hypogonadism, they also can suppress the HPA axis, less commonly than hypogonadotropic hypogonadism. And people have estimated maybe between 10 and 20% of opioid users can get suppressed HPA axis function. However, it's not that suppressed. In fact, reports of an adrenal crisis in these patients is very rare. There's maybe a couple of case reports. So they have enough cortisol to prevent an adrenal crisis. Probably what they don't have is enough cortisol if they get really, really sick. Stress doses is what we call it. Again, secondary is usually milder because it's slower in onset, less severe, and there's an intact renin-angiotensin system. Now, this is the simplest approach, and in fact, is the approach we use. We don't start out with the $1 million workup. If we suspect adrenal insufficiency of any kind, don't care what causes it, we measure a morning cortisol, DHEAS, and we usually grab an ACTH. The reason is, in some of the guidelines you'll read, they say, oh, you'll measure the ACTH later. Well, the fact of the matter is it's a different tube type for ACTH. That's done in EDTA plasma. Cortisol and DHEAS are done on serum. So if the patient's from, in my case, Superior, Wisconsin, we're not going to have them drive the 12 hours already all the way back just to get an ACTH level. So we often, if this index of suspicion is high enough, we usually get these 3 tests. It costs more to park at the hospital than an ACTH costs. If the cortisol is elevated, not low, and the DHEA is not low, you've pretty much excluded adrenal insufficiency. We do this in the morning again, when it should be at its highest. Now, each lab has a slightly different cutoff, so you should check what your reference range for your laboratory is. If the cortisol and DHEA are very, very, very low, and the ACTH is elevated, they have primary adrenal insufficiency. If the ACTH is not increased, inappropriately not increased, they have secondary adrenal insufficiency. If the cortisol is intermediate between low and normal, we do ACTH stimulation testing, which I'll show in a minute. But I will go off the record here and give you a caveat. If the physician has a high index of suspicion, they do all of this, but many of them still just go ahead and do the ACTH stim test. One reason is they want to follow the recovery of the patient if they have secondary, because you can use ACTH stims to follow the recovery of the HPA axis. So this is an ACTH stimulation test. I'm sure you all know about it. It's one of the most common, maybe the most common, dynamic endocrine tests done. Now, cosentropin, in Europe it's called synacthin, is synthetic ACTH 1 to 24, the business end of the molecule. And this is an enormous dose of ACTH. The normal ACTH levels up to 50 in most assays. This raises ACTH to 50,000 or higher. So it's a sledgehammer to the adrenal gland. It's the maximum the adrenal can do. And so we get a basal level, we inject ACTH or cosentropin, and we get a sample at 30 and 60. It's The peak is almost always 60, occasionally 30. We don't do the 120 measurement. It's not worth the trouble. And obviously, this is a normal response. If the adrenal's destroyed in Addison disease or primary adrenal insufficiency, obviously it's not there. You don't get a response. Sometimes it's not zero. It could a little bit, but the assay down at that end isn't that great anyway. It kind of doesn't matter. This is so unbelievably subnormal. Who cares what the actual number is? Now, in secondary adrenal insufficiency, particularly if it's been going on long enough, their basal cortisol is low. But you can get a little bit of a response with that small amount of adrenal function that's left. But it's clearly subnormal, way below the cutoff. And that's the screening test for any type of adrenal insufficiency, regardless of the cause. Okay. Now, some of this may not be relevant to your practice. Some of it may be very relevant. But this is an example of the differential diagnosis. At our institution, the primary care doc's zone stops here, and the endocrinologist takes over below that. In some places, my brother-in-law is an internist, he takes it all the way down. So it really depends on your practice. But we've made the diagnosis. We know the patient has adrenal insufficiency. Now the question is why? If they have primary, again, I've already told you they have IACTH, high plasma renin activity, and low aldosterone, plus the low cortisol, immediately put them on steroid replacement. Because you can do the rest of the workup while they're being treated. You don't want to wait for them to go into an adrenal crisis. Unless there's a reason not to do it, first thing we do is measure anti-adrenal antibodies. And the one we typically measure is against 21-hydroxylase. Don't worry about what that is. It's the most common cause of autoimmune adrenalitis. If it's positive, you nailed it. However, it's not always positive, even in autoimmune adrenalitis, because there are other antibodies, but also sometimes the antibodies have waned. You miss them, just like antithyroid antibodies. But if you're convinced it's not Addison disease and not autoimmune, we look for other causes. Adrenal leukodystrophy in males. So we measure very long chain fatty acids. We say, could the patient have infection? We also look for granulomatous disease sometimes, but typically we look for infiltration. And we've had patients with bilateral lymphoma who nobody knew they had it. Adrenal hemorrhage, which is actually much more common than you think because of all the drugs now that are using that affect clotting. And then congenital adrenal hyperplasia, I'm not going to talk about it all today, but of course, the whole reason why they have this syndrome is they can't make cortisol adequately. Secondary adrenal insufficiency, you immediately put them on glucocorticoid, but not mineralocorticoid. In fact, that could be bad for them. You could lose control of their potassium. And other than the physical exam and the history and everything, they were in a car accident. That could be the trauma that we're looking for. A pituitary-directed MRI. If it's positive, they have a lesion there, then you meet up with the surgeons, the neurosurgeons, and you decide what to do. If the MRI is completely normal, could this be glucocorticoid-induced secondary adrenal insufficiency? Now, typically you ask that way back here, but some patients surprisingly don't realize that that epidural injection they got a month ago could be causing this. So then you go back and you talk to the patient again. Are you sure you didn't get any steroid therapy? Again, a history of head trauma. And in our case, opioids. And this one can be a real challenge, as you all know much better than I do. So, in summary, testing for adrenal insufficiency should be done with a relatively low index of suspicion, because if you miss it, it could be a very bad outcome. Morning plasma ACTH and serum cortisol is a good starting point. Notice I'm hedging on DHEA. Some people say, it's a waste of time. Some people say it isn't. I'm a lab guy, so I say order as much as you can rather than having to have the patient come all the way back to have another blood sample done. Real pain. But some doctors just do the plasma ACTH and serum cortisol. If called for, as I already described, the standard 250 microgram gocentropin stimulation test with cortisol measured at baseline, 30, and 60. And whichever one's the peak is the one we use, but it's almost always 60. And the cutoffs vary from lab to lab, and you need to know what your lab does. As a very, very quick caveat, there have been lower dose ACTH stimulation tests developed, all different ilks and varieties. We've stopped doing it because it just doesn't work as well. I'm going to leave it at that. Well, thank you so much for your attention. If you have any questions, I'm sure they can be directed to me through the company that is facilitating this recording. Thank you very much.